Antibody-drug conjugates represent a new therapeutic for patients with multiple myeloma. We already have proteasome inhibitors, we have immunomodulatory agents, and we have naked monoclonal antibodies that target either CD38 or SLAM-F7. But there is this new class of antibodies linked to a potent toxin, which leads to the targeted death of a myeloma agent. A number of different antibody-drug conjugates are undergoing clinical evaluation, but there is only one that is now licensed both by the FDA and by Europe. That is called Belantamab Mafodotin and is an antibody-drug conjugate that targets BCMA. In the pivotal Phase II DREAMM-2 clinical trial, the overall response rate was approximately 30% for patients who are triple-class refractory, and we know that this is a difficult-to-treat population. For those patients who did respond, the median durability of response was approximately 12 months. So clearly, if you respond to this antibody-drug conjugate, you can get quite a good, durable response, whereas patients would normally do quite badly at this stage. In general, it's quite well tolerated. The main adverse event is thrombocytopenia and keratopathy, and that's when microcysts form on the front surface of the cornea. That can, in a proportion of patients, lead to blurring of vision and grittiness on the eyes. However, this is readily managed by dose interruption and giving regular preservative-free eye drops, after which the corneal microcysts resolve and the patient is able to resume treatment. Belantamab Mafodotin is also being investigated in combination with standard of care agents such as Bortezomib, Lenalidomide and Pomalidomide, and indeed with some new immunomodulatory agents. So in summary, antibody-drug conjugates represent a new class of treatment for myeloma. They're in effect the fourth pillar, along with proteasome inhibitors, IMiDs and CD38 monoclonal antibodies, and provide a meaningful response for patients with relapsed refractory myeloma.